All right, welcome to this session. In this session, we'll talk about the basic pharmacology of antihypertensive agents. Now, one thing you will know is that all antihypertensive agents they work at either one or more of that four anatomical sites I discussed earlier, either one or more of those four sites. And when they are working at that site, they tend to counteract the effect of the blood pressure regulatory mechanism. That's what they try to counteract. Okay. Now, there are four main classes of antihypertensive agents. We have sympathoplegic agents, we have direct vasodilators, and we have drugs that act on the renin-angiotensin pathway. Okay, so those are the four classes of antihypertensive agents. All right. Now, if you look at this diagram just summarizes everything. So let me just show you first. We have what I said. We have what sympathoplegic agents. We have direct vasodilators, and we have drug that act on angiotensinogen pathway. Okay, that drug that acts on RAS pathway. Now, if you look at this diagram summarizes everything. So this is the brain, right? Then this is your sympathetic ganglion. These are your sympathetic nerves. Okay, these are your sympathetic nerves. Then any drug acting from this brain down to the ganglion, down to the innervated organs, they are called sympathoplegic agents. They are trying to inhibit the sympathetic nervous system. So you can see from this diagram that they are now further divided into various classes. Okay, please don't mind the noise in the background. They are now further divided into various classes. We have the ones that we act centrally. So we call them the ones that we act on the vasomotor center. That's where you have your methyldopa, clonidine, guanabens, and guanfacine. Okay, these are drugs that act centrally. Then also we have the ones that we act on the ganglia level. That's where you have trimethophan. Okay, we also have the one that we act on the nerves, like they will inhibit the release of the neurotransmitter on the nerves. That's where you have sympathetic nerve terminal drugs, the one that will act on the sympathetic nerves level. We have guanetidine, guanidine, and rezepine. So all these drugs I've been mentioning, they are all sympathoplegic agents acting on different levels. These ones are acting at the central level. These ones are acting on the ganglion level. Okay, these ones are acting at the nerve terminal level. Guanetidine, guanidine, and rezepine. Okay, then also we also have the ones that we act on that will block the receptors. So you can see the one that will block beta receptor on the heart. We have propranolol and other beta blockers. Okay, we also have the one that we block alpha receptor on the blood vessels. We have prazosin and other alpha 1 blocker. Okay, all these drugs I've mentioned so far, they are all sympathoplegic agent. Even together with this one again, this is a beta receptor here, so they will block the beta receptor located in the kidney. Again, you can see propranolol and other beta blockers here. Okay, so far I've explained I've shown you the sympathoplegic agent and the four sites in which they work on: centrally acting, ganglion, nerve terminal, and the receptor level. Okay, then also we now also have the ones that the direct vasodilator. So you can see here, this is your vascular smooth muscle. We have the direct vasodilators. We have hydralazine, minoxidil, nitroprusside, diazoxide. We have verapamil, calcium channel blockers, phenadopam. Okay, all these ones, they are all direct vasodilators. We will look at them as we proceed. Then also we have the ones that we add on the renin-angiotensin pathway. So you can see them here. That's where you have your captopril and other ACE inhibitor. You get. We also have your angiotensin receptor blockers, losartan, and other angiotensin receptor blockers. Okay. Then lastly, we have the diuretics. So the diuretics are your thiazides and other for example, your loop diuretics, spironolactone. Okay, so with this now, you can see that all the drug you will encounter in antihypertensive chapter works in this place. They are all in this diagram here. They are all in this place, starting from sympathoplegic agent, diuretics, direct vasodilators, and agent that blocks angiotensin pathway. Okay, so let's continue. Let's continue and discuss diuretics. So diuretics are drugs that alter sodium and water balance. They alter what? Sodium and water balance. So you will notice that it has been shown that if you can restrict sodium intake, you will be able to control your blood pressure. So dietary sodium restriction has been known for many years to decrease blood pressure in hypertensive patients. Now, when they now brought up the idea of diuretics, most patients now felt that, oh, it is now less important. That's what they thought. So it was thought that taking if we should continue this our sodium restriction, it won't really play any more shows. You get so, but it has been shown that if you can continue with salt restriction, that is to say sodium restriction, it is even more safer. So it is a relatively non-toxic therapeutic measure. So you should not say that, oh, I'm already taking diuretics, no need for me to restrict my sodium intake. No, you must what? Continue with what? Restriction of what? Sodium intake. So that is one aspect for you to take note of. All right. Then the next thing I will talk about is the mechanism of action of diuretics and how they affect your what? Your blood hemodynamics. What is the mechanism of action of diuretics? Now, the primary way in which diuretics work is by depleting body sodium stores. Okay, that's what they do. That is what they do. They deplete your body sodium stores, and by depleting your body sodium stores, they will decrease your blood volume. Okay, and once they decrease your blood volume, you know what will happen? Venous return will be reduced. Then if venous return is reduced, it means your cardiac output will reduce. So initially, when you give diuretics initially, they will reduce the blood pressure by reducing blood volume and cardiac output. That's what they will do initially. Then also during this initial period, your peripheral vascular resistance might increase. That is because of the compensatory mechanism, because the body will see that, oh, you are reducing your cardiac output, so the body will fight back by increasing peripheral resistance. Okay, that's what will happen initially. Okay, then after about 6 to 8 weeks, of taking this particular diuretics, the cardiac output will return back to normal. However, the peripheral resistance will now what? Decline, because by this time around, your body sodium has decreased drastically. It has decreased drastically by the diuretics you are taking. I know sodium is usually coupled with calcium. There's a particular channel that is called the sodium calcium exchange channel. This particular transporter, at the end of the day, tries to like increase the intracellular calcium level inside the cell. And if you are able to remove sodium from the body, it means that this exchanger will not be able to work. You get, so your intracellular calcium level will decrease. And if you can decrease intracellular calcium, it means that your contraction and the rest will be altered, will be stopped. So by so doing, it helps to reduce your peripheral vascular resistance. The main thing it does is to deplete body sodium. If you can deplete body sodium, it means that calcium entry into the cell will be altered. You get, so that is the main mechanism of diuretics. But initially, there will be a decrease in cardiac output. Then after 6 to 8 weeks, cardiac output will remain normal. Then your peripheral resistance will not decrease. So let's proceed. So again, if you are taking diuretics, it has the ability to reduce your blood pressure for just about 10 to 15 millimeters of mercury. That's what it does. Okay, so if you're taking it alone, it can reduce your blood pressure by 10 to 15 millimeters of mercury of mercury for most patients. Okay, and we usually give diuretics for just mild to moderate hypertension, essential hypertension. However, in severe hypertension, we switch our drug to sympathoplegic agent and vasodilators. These are the drugs we will now use. So in severe hypertension, we switch from diuretics to sympathoplegic agent and vasodilators. Now, the idea behind using this drug is that there's a problem there, in the sense that if you are using sympathoplegic agent and vasodilators, your blood vessel will appear stiff, in the sense that sympathoplegic agent will prevent vasoconstriction, to occur. Then vasodilators agent will keep the vessels dilated. So that flexibility of the blood vessel will not be there. One is preventing contraction, the other one is making it to relax. So the vessel will just appear as a inflexible tube. And if you have that inflexible tube, the tube is left in the mercy of the amount of fluid inside. So the tube is left at the mercy of what? The amount of fluid inside. If the amount of fluid increase, the blood pressure will spike. That's why whenever you are using sympathoplegic agent and vasodilators, we usually tend to control the blood volume by giving what? Diuretics. That's where diuretics comes into play, to control the blood volume so that we can maintain it at 95% of the normal. If it's more than 95% of normal, let's say it's around 105% of normal, then it will lead to what? A high blood pressure. You get? So that's what you should take note of. That when you are combining sympathoplegic agent and vasodilators, you will usually add diuretics to control the blood volume, because anytime you are combining those two drugs, the tube will appear as a what? As an inflexible tube. So you get? So as a consequence, the blood pressure will become what? Exquisitely sensitive to what? To blood volume. So that's why we test to control the blood volume by diuretics. Now let's proceed. What then are the use of diuretics? The main use of diuretics, like I've explained, is for mild to moderate hypertension. That's what we use it for. Mild to moderate hypertension. Okay, so the patient must have a normal renal function and a normal cardiac function. Okay, that's the main use of what? That's for thiazide. Now this one is for thiazide. So the main use of thiazide, diuretics are of different class. We have thiazide, we have loop, we have carbonic anhydrase inhibitors. Okay, so there are different kind of diuretics. We will have direct acting ones, those ones that are osmotic diuretics. So take note of that. But for thiazide, we use thiazide mainly for mild to moderate hypertension and with normal renal or cardiac function. So that is for that. Now among the thiazide, chlorthalidone is more preferred to this other one, hydrochlorothiazide. Chlorthalidone is more preferred to hydrochlorothiazide because it has a longer half-life. You can take it for it can work for what? 24-hour blood pressure control as compared to hydrochlorothiazide. So that is one important thing to take note of. But if we are talking about severe hypertension, in severe hypertension, we switch our medication from thiazide to loop diuretics like your furosemide. So loop diuretics, those ones work at the loop of Early. Okay, that's where they work, and they are more powerful. So the time we use them is in severe hypertension and patient that has a low GFR, because the only time you see people using furosemide, the patient condition must have deteriorated such that you are now seeing fluid build up in the body. There will be fluid build up. So what we call fluid build up is when your GFR level is already less than what? 30 to 40 ml per minute. Okay, this one will lead to fluid build up. So we need to remove the excess fluid from the body. Then also patient with cardiac failure, again cardiac failure will lead to fluid build up. Liver cirrhosis also will lead to what? Fluid build up. So these are the things you should take note of. Alright, so apart from that, we also have the potassium sparing diuretics, which is your spironolactone. Okay, so these ones they are both useful to prevent excessive potassium depletion, because the main side effect of taking diuretics is potassium depletion, and to counter that potassium depletion side effect, we usually mix them together. We usually add spironolactone also to the medication in order to ensure that potassium is not lost from the body. Okay, so that is the use there. So then again, spironolactone also has a way of aldosterone receptor antagonists in particular also have a favorable effect on cardiac function. Okay, because it tries to like prevent the cardiac remodeling of the heart. You get. In fact, that is spironolactone. Spironolactone also what? Also has this cardiac remodeling function, okay? Because spironolactone is aldosterone receptor antagonist, okay? Spironolactone is aldosterone receptor antagonist. That skipped my mind just now. All right, so that is for that. Then, so that means that if your patient is taking spironolactone, it helps to improve their cardiac function. Okay, so that is that. Then lastly, we'll talk about the toxicity of diuretics. The toxicity of diuretics. The main toxicity, like I explained before, is potassium depletion. Potassium depletion. That is the main toxicity of what? Diuretics. Potassium depletion. So this particular potassium depletion, which is hypokalemia, it may be hazardous in what? In patients already on digitalis, because digitalis will what? Digitalis toxicity is increased in hypokalemia. Digitalis toxicity is what? Is increased in what? In hypokalemia, or those that have chronic arrhythmias, or those with acute myocardial infarction or left ventricular dysfunction. So if you see a patient that is already a cardiac patient, any change in their potassium level will be disastrous for that patient. So you should mind the drug you are giving to those patients, and you should be able to monitor their potassium level for them. Okay. Then apart from that, if you can restrict your dietary sodium intake, that one will also help you to reduce potassium loss. Okay, because the more sodium you take in, the more potassium that will be lost from the body. That's how it works. The more sodium you take in, the more potassium that will be lost. So if you can restrict your dietary sodium intake, it's going to help you a lot in curtailing hypokalemia. Okay, so that's one thing you should take note of. Then also, as a side effect of diuretics, they also increase your serum lipid level. They cause impaired glucose tolerance, okay, because they will increase glucose level, increase lipid level, and also increase uric acid level. These are some of the side effects. And when uric acid level is increased, it will what? Precipitate gout. Okay, so that's one thing you should take note of. Then for the potassium sparing diuretics, their own side effect will be hyperkalemia. Okay, and this will be more disastrous if the patient already have renal insufficiency. Okay, so if a patient is already having renal insufficiency, giving them spironolactone is disastrous, because they will not be able to, the hyperkalemia, they won't be able to manage it because their kidney is already failing. Also, if a patient is on ACE inhibitor or ARBs, angiotensin receptor blocker, you should avoid giving them potassium sparing diuretics, because ACE inhibitor and ARBs, they already tends to increase your potassium level in the body. So combining it with potassium sparing diuretics like spironolactone will be disastrous. So that's one thing you take note of. Then lastly, spironolactone has been shown to have gynecomastia effect. So this is everything about this section. In the next video, we will continue from drugs that act on the sympathetic nervous system. Okay, so we are done with diuretics now. Thank you very much. So you can also subscribe to this channel. All right, thank you.